The following program, Live and Learn, is made possible by Aging Partners. Find out more on their website at agingpartners@lincoln.ne.gov.
I'm Lita Powell Drake. If you have to go into the hospital, do you know whether you're an inpatient, an outpatient, or under observation? If you don't know, your insurance may not cover you. Stay tuned for Medicare, a bitter pill.
I'm Kristen Stowes, and today I will be discussing hospitalization and dismissal procedures.
I'm Chris Beckenbaugh. Today I'll be talking about selecting a rehabilitation facility with my guest, Amy Goldman.
My name is Tom White, and today I'll be speaking with Joyce Kubicek and Sandy Lutz from Aging Partners, and we'll be discussing what to do after hospitalization or rehabilitation.
This and more on today's Live and Learn.
It's a bitter pill to swallow when you have Medicare, supplemental insurance, you have an accident, you go to the hospital for surgery, and you find out that you're not covered because you're labeled an outpatient. I want to tell you what happened to me. And Houston Doan from Aging Partners is here to kind of give us some ideas of how to avoid the trap that I got in. I have not been in the hospital in 54 years except to have a baby. Spent a night in a hospital for 54 years. Now I was all covered with Medicare and Blue Cross Blue Shield, long-term care, everything. December the 4th, I went out to get the Lincoln Journal-Star, and it had rained the night before, and it froze. I didn't realize that. My driveway is sloping down. I stepped on it and fell, fracturing my left knee in 4 places. The pain was beyond belief unbearable. I didn't know what to do. I lay there in the driveway with the pain. Didn't even occur to me to call 911. I've never called 911 in my life. So it didn't occur to me. I didn't have a cell phone anyway. I'm lying there prostrate in the driveway, and thank goodness a neighbor drove by, looked over, and and realized I was lying there prostrate, and so she stopped the car and helped me in. Can I help you? And I said, I think I'll be all right. I mean, I didn't know I'd fractured the leg. All I knew was it hurt a lot, but I thought I just twisted it. So she helped me in. I found an old pair of crutches in the garage, and I said, I'll be okay. I'll be okay. Well, I wasn't okay. As the day progressed, the pain increased. I thought, oh dear, what have I done? So I called my primary care physician. They could see me the next day. So I had to have my neighbor drive me in his old truck because, once this happens, you ain't going anyplace. And you can't drive. And so I went to my primary care physician. He took an x-ray and said, oh, you've fractured your knee in 4 places. You're going to have to see an orthopedic surgeon. So they called an orthopedic surgeon, and appointment was made for the next day. I had to get my neighbor, thank goodness for neighbors, to drive me again. And they did an MRI and said, oh, you have an ORIF, open reduction internal fracture. We have to do surgery. How about tomorrow at 10:30? Well, now, once you live alone, you just can't walk out of your house. If you're knowing you're going to go to the hospital, you don't know how long you're going to be there, then you've got rehab. So I just said, I'm not ready to go tomorrow. And they give me some pain pills. So, it wasn't so staggering at that point. I can't go tomorrow. And he said, okay, next week. So I waited a week. Okay. The time came for the surgery a week later. It was set for 5 o'clock at one of our major hospitals. I didn't like the idea that it was that late at night because I thought if the surgeon's been operating all day, but he's going to be tired by the time he gets to 5 o'clock and he'll cut off the wrong leg or something. But at least I could tell that the person who gives the anesthesiologist or anesthetist, I'm not sure which one he had a sense of humor. And I said to him, all right, what are you giving me? He said, I'm giving you Jacko juice. I said, Jacko juice? Michael Jackson, you're giving me propofol? He said, we give it to everybody. I said, but you killed Michael Jackson. He said, well, we're not going to kill you. I said, oh, Michael Jackson is expendable, but you're going to save me? He said, oh, it goes down like milk. And I said, yeah, Michael Jackson asked for his milk, and he's dead, and then I was gone. Okay, the next morning I was shaken, awake. I don't know. There was a woman there. I heard her voice. I don't know if she said anything before, but she said, what I heard her say was, where are you going? And I said, I'm not going anyplace. I'm in the hospital. She said, no, you can't stay. I said, no. I thought maybe she had the wrong patient. I said, they operated on me last night. See, I got this brace. They did an ORIF. And she said, no, you can't stay, you're too healthy. I said, no, they cut me open, I have to stay in the hospital here. And she said, no, you have to be in the hospital 3 days and 3 nights before we can send you to rehab and it's paid for. And I said, but you're throwing me out. I should be here for 3 days. She said, no. And so then she said, where are you going to go? And I named one of the big rehab centers, and they said, that's $600 a day. And I said, I've got insurance. I've got Medicare, Blue Cross, Blue Shield, long-term care. And she says, it's not covered. And so I named another place. She said, that's $550 a day. I was thunderstruck. And so I named another place. She said, that's $265 a day. That's where I went. And I was there for 11 days. They treated me well, and I was happy with it. But I got to pay for everything. Okay, I want you to avoid this. That's why Houston Doan is here. Where did I go wrong, Houston Doan?
You didn't go wrong,
Oh, yes,
Lita.
I did.
It's the system. And unfortunately, you did everything correctly. I know because we've talked prior to this, and you made the right phone calls. You did ask the right question.
I did call Blue Cross
Yeah.
and Blue Shield, and
Yeah.
they said to me, "You will be if Medicare covers you, we cover you." I
Right.
thought, fine,
I'm fine.
I'm in good shape.
Yeah. What happened, and this happens with great frequency, as you are now finding out, there's a distinction between inpatient and outpatient. You were an outpatient.
Well, I figured I was an inpatient because I was in the hospital.
Right, but to be an inpatient, you have to be admitted as an inpatient in the hospital. Many people find themselves in the hospital, in a hospital bed, much like you, for observation as an outpatient. It's tough.
Who makes that decision then? Who determines whether an inpatient, outpatient, or under observation?
Typically, your doctor is the gatekeeper. Surprisingly, today, many primary physicians are no longer your primary physician
Yeah.
when you enter the hospital because the hospitals have their own physicians that take over. So you have a number of gatekeepers that can make this decision. So when you do find yourself in this position, of course, the first thing I'm going to tell you anybody to do, you need an advocate. You need somebody else there with you.
Because you're frightened, you're under anesthesia. I
Right.
didn't even know what I was saying.
You had
a
no
friend
idea.
came to visit, was there. I didn't even know she was there.
Yeah.
You don't know anything, and when the woman awakened me the next morning, I didn't even know where I was or what
Yeah.
she was saying or what I was saying.
Right. And, you know, there are a number of things you can do. Of course, you should every day ask your status. Am I an inpatient or an outpatient?
To whom are you
To-
asking?
You would ask the hospital staff themselves that question. Now, ironically, you can be an inpatient one day, an outpatient the next, and they can retroactively change your status. Monday I was an inpatient, Tuesday I'm an outpatient. Oh, by the way, we changed Monday to an outpatient as well. You need to ask these questions. You need to have your advocates know to ask these questions.
Yes, but when you have an accident, then
Yeah.
you're going to the hospital,
Right.
and so you haven't had a time to really prepare. But now we're saying if indeed you're going to have to go in for surgery, you consider some of these things.
Right, absolutely. Now, the backside to that is typically, if you were in an accident, let's say, then that's something called critical care. Critical care, automatically you become an inpatient.
You mean if I had called 911, that therefore I would have been?
You probably would have been admitted as an inpatient because you would have gone through the ER. They would have seen how extensive your injury was and probably said, let's put her in until we can operate on her. Yeah.
So I made big mistake.
Well, no, you did what everybody in Nebraska does. we're independent. That's good and that can be bad. And we take care of ourselves. Golly, okay, I probably sprained my leg. I'm going to get back in the house and I'm going to be fine.
That's what I
It just didn't work out that way. But
The pain was telling me that this wasn't all right,
yeah.
that I had done more than just twist my knee a little bit.
yeah.
Oh, and I just wanted to tell you, because what they did, this ORIF, I was talking about the actual surgery, what they did, this is your kneecap. All right, they put wires all around the kneecap, 2 little rods of steel to hold the wires. And inside the circle, 360 degrees, is a figure 8 of wires. So I was really wired. Then they slap you in a brace where you can't move it, because all this has now got to heal, because they cut you open and 21 staples. They don't even stitch up anymore. It's been so long it's been in the hospital. I said, you're going to just staple me? Okay, how do we avoid the traps?
Well, first of all, an advocate. Second of all, you need to ask the questions. If you find yourself in an outpatient status, you can either A, ask your primary physician to reconsider that status, or the hospital physician to reconsider that status. If you find yourself discharged, much like what you found yourself, boom, I'm on the street. I did not have those 3 midnights, those 3 days. That means that Part A would have paid for the skilled nursing facility. You were actually in the hospital, and your bills were being paid by Part B as in boy, which means you also were liable for 20% of the bills. Of course, your Blue Cross took care of that. But, that's the problem. Under Part A, you get one set of coverages, including the skilled nursing rehab. Under Part B, you don't.
Well, it cost me thousands and thousands of dollars. I don't want this to happen to you. And then you're going to wind up when the people start coming in to help you because you can't maneuver around the home. And so these are things you have to purchase. This is really wonderful. This is a railing that goes on the bathtub, because once you've had a fall like that, taking a bath or a shower is terrifying. You never thought about it before. So this is something you can screw onto the side of the bathtub, and it holds you, and it's very heavy. This will cost you about $60. I got more. I got more stuff. Okay, now I didn't want to bring the toilet seat itself because I'm using them. But you know what happens? To sit down on the toilet, you really need the elevation, because it's too, you never think about this before it happens. To sit way down is difficult. So these are $80 each. And I had to buy 2 of these, so that's $160. I'm just adding some of the stuff up. One more thing I've got here. How about the walker? Where'd you put that walker?
I think it's over there.
There's a walker right there. Yeah. Okay, here, I'll just get it real quick like here. Okay. This is a walker. This is a different kind of a walker, a standard walker. You're going to need that. You're going to need that. And I really needed 2, because I have a 2-story house. I needed one for upstairs. And Medicare will give you 1 walker for free. But I needed 2, so that's $100. And then the basket, because you got to carry stuff. That's $27. So you start adding all that stuff up, and it is sizable.
Yes.
It is very sizable.
Absolutely.
Okay, so now what?
Well, if you find yourself having gone through what you've gone through and you've been discharged, many times a person could have access to rehabilitation services offered through your home through Medicare. You, of course, had a substantial injury, and probably that would not have worked. But for many people, they should ask their doctor, look, I was outpatient, I don't get skilled nursing, can I get some home health care through Medicare to help me through the first week or so of my recovery?
I did have that.
You did
and
have
they were very good. They were very
good.
helpful.
Yeah.
But I was just so shocked. because this has never happened before, and what the price that it cost me. So the reason we have really gone over this is we don't want this to happen to you what happened to me. So be prepared. You better know the difference between inpatient, outpatient, or under observation. You better call your insurance coverage and talk to them, and talk to your doctor.
Doctor's the gatekeeper.
Doctor, and bring, if you have to go to the hospital, bring a friend, a family member, bring them with you, because they're going to give you all these drugs and you don't. Well, I'm having fun here, aren't I, in the hospital? Houston, thank you so much.
Thank you, Lita.
For the preparation and the advocacy you have for seniors.
Thank you, and I appreciate the opportunity.
Okay, and remember, it is never too late to live and learn.
At some point in each of our lives, we will find ourselves being admitted to a hospital. I'm Kristen Stoes, and I am going to find out exactly what to expect from a hospitalization and a dismissal as I talk with my guests, hospitalist Dr. Brian Bossert and Bryan Health Care Management Manager Susan Mulligan. Welcome to you both.
Thank you.
Dr. Bossert, I'd like to begin with you by having you simply define the term hospitalist.
Well, sure. Hospitalist is a provider who devotes essentially 100% of their clinical and professional time to the management of a hospitalized patient. There are roughly 50,000 hospitalists now in the country, which is an amazing number given the fact the term hospitalist wasn't defined until 1996, and so in less than 20 years we now have 50,000 hospitalists, which is the largest medical specialty in the country.
That's amazing. That's amazing. And I know that you have had a major involvement in the hospitalist program, both locally and nationally. Could you please tell us a little about that?
Well, I've been doing it a long time. Started 21 years ago in 1993, providing hospitalist services at Bryan Health West Campus. And at the time, we didn't even have a term for it. But from there, was able to get involved in the National Association of Inpatient Physicians, which eventually evolved into the Society of Hospital Medicine. Worked on national committees for quality improvement through the Society of Hospital Medicine, and I was on the founding physician team, Team Hospitalist, which is a physician advisory team for the Journal of the Hospitalist. So I've been blessed to be a part of all of that.
That's wonderful. Very, very, very good. After a patient checks in, then, when is the first contact a hospitalist might make with that patient?
Well, it's right away. Typically, a patient is seen in the emergency department. The emergency department care team will evaluate the patient, establish needs, provide the triage, and then contact us if they feel the patient needs to be admitted. Many times we'll see the patient in the emergency room, or at times we'll wait until the patient is transferred up into the acute care area, maybe the intensive care unit, and we'll see them there. But we'll see them very soon after they reach the hospital.
I see. And do you and the patient's primary care physician work together during this hospitalization?
We do, and that's very important. Sharing information, whether it's documentation for previous office visits, sharing information over the phone is also an important piece of how we communicate with each other. Now, with computerized medical records, sharing that information has become more seamless.
I see, I see. Does the hospitalist then make the major decisions about the patient's care in terms of if they need to see other specialists or about pain control directives, those kinds of issues?
Yeah, as the attending physician, we absolutely do. We establish the needs early on. We identify specialty care that might need to be involved, whether it's medical specialty care or surgical specialty care, and then sort of drive the ship from that standpoint.
Okay. And you also coordinate between physicians?
Right. The communication between physicians is important, and we make sure that that process is seamless as well.
Well, this system could be very new. As you said, it's only 20 years old. So if someone hasn't been hospitalized for 20 years, they need to understand that it is the hospitalist that they will be seeing mainly in the hospital, probably not their primary care physician.
Right, and that's the primary care physician's decision, whether they would like us to assume that care in the hospital stay or whether the primary care physician will continue to see the patient in the hospital. It's up to the primary care physician, but the majority of the care now in the hospital setting is being provided by the hospitalist.
I see, okay. Susan, if I could please bring you in at this point. When does your job as care management consultant start to serve this patient?
We typically will see the first day.
Okay.
We start right off the bat, sometimes in the emergency department, sometimes when a patient's admitted to the unit. If they admit late in the day, then sometimes it's then the next day within those 24 hours, first 24 hours.
I see. And can a family's input be important?
It's crucial.
It's crucial.
And we really try and talk with them from day one as well. Whoever the patient identifies as their support person or their family, they're involved all along.
Okay. How does a patient's diagnosis, treatment, and even their prognosis affect their discharge?
Well, depending on what their diagnosis, treatment, recovery needs are, will determine what kinds of services they're going to need. So, for example, if they have a planned orthopedic surgery, they may or may not need facility care for rehabilitation. Okay. Sometimes they can go home with therapies or services in the home. So it really depends on other things that they might have going on in conjunction with that surgery, as well as how they were doing before they came into the hospital, and then what services they had prior or will need then when they go home.
So it's really important that you find out everything you can about that patient early on so you can start planning.
Yeah, absolutely. That's why we start day one and we assess and find out from them what services they had, what their functional status was, who their support system is.
Do you have a dialogue with the patient's insurance company at this point?
We do. Very early on, we make sure that there's coverage for their stay in the hospital as well as then for services that they need when they leave the hospital. And that's continual while they're in the hospital as well.
I see. And what about patients who may not have health insurance?
We do have advocates that see patients that don't have insurance, or maybe they have insurance but it doesn't cover what's needed. And so those advocates, they'll talk with the patients and the families to see if there's assistance programs that they are eligible for, and then they'll help them make application for those.
Okay. Dr. Bossard, then is it the hospitalist that makes the decision when the patient is ready to be dismissed?
It is. As the attending physician, the hospitalist will identify those needs that the patient may have, and we'll make that ultimate decision on when the patient is ready for discharge.
And what specific criteria needs to be met by the patient medically to be discharged safely?
Well, interestingly, each patient's needs are different, and so for each patient the criteria will be different. Depends a little bit on the patient's chronic medical conditions, whether they have a chronic lung disease, for instance, or congestive heart failure, diabetes, those sorts of things. Also depends a little bit on the disposition, what facility they're going to be discharged to, whether it's a skilled nursing facility, whether it's a rehab facility, home, or even hospice if that specialty care is going to be required. Different criteria then will determine whether the patient's ready for discharge.
So I can imagine it's a long list of
possibilities and lots of variability in terms of what determines that.
Many issues to address. Do you then let the primary care doctor know that this patient is being dismissed?
We do. After that whole process is worked through and we identify the perfect spot for discharge, we work with the primary care physician in terms of identifying what's happened during the hospital stay, what the immediate needs will be once the patient is discharged, and where the patient is being discharged to.
Okay, all right. Susan, what then are the criteria that you focus on in your area?
Well, we focus on criteria for discharge in terms of the safe plans being arranged, whether it's services in the home or if they need to go to a facility for some rehabilitation or to a facility on a long-term basis. So we make sure that those arrangements are in place. If they're discharging to home, that the home services are set up to start the next day. If they're discharging home, that they have a follow-up appointment made with their primary care physician, usually within 7 to 10 days. That's very important for a safe discharge. And then additionally, if they're transferring to a facility, to make sure that that facility can offer the level of care that they need. And then we check to make sure that there's openings at preference facilities. Sometimes we have to go to a second or a third choice if their preference facilities are full. And then just making sure that the transfer arrangements are solid and family's been notified and that things are safely arranged before they leave.
So a patient's preference as to where they might be going is foremost?
It is, and actually we're required by Medicare and Medicaid services that we do offer choice. And that's part of that initial planning that we do with patients and families.
And if that is not available, then you do make other recommendations.
Right. We usually try and get 3 choices, if not more, if the first or the second are full.
Oh, that's a good,
and we try and do that early on, so they're educated that they might not get their first preference, but we always try for that.
If there's an opportunity for the patient to visit an extended care or rehab facility before their hospitalization, would you recommend that?
Absolutely, and that's the best time, really, if it's especially for a planned procedure, that you do it when you're not as anxious, when you're not in crisis, because usually you're in some type of crisis, even if it's a planned admission to a hospital, because it's different, it's unfamiliar.
Sure, sure. So you spoke about a patient's safe plan. Is it paramount importance that that be in place before the patient is discharged?
It is.
So it is truly dependent upon that.
Yes, and that's why we start so early, just to make sure that they're educated, they participate in the process, both the patient and the family, and that they have enough time if they do need to make some of those visits or contact different family members to know who's going to help, that we start that as early as we can.
So there's a lot of dialogue that goes on between you and the patient and the family even.
Absolutely.
Do you give any follow-up to the patient once the patient is discharged?
Patients that discharge home are part of a process for discharge follow-up calls, and those are made by the nursing units. And it's to check to make sure that the scheduled services have started, that they understand their medications, if they have any questions about the education that was provided to them before they go home. That is a follow-up call that happens within the first few days after discharge.
I see. Okay. Is it okay if family members call you back after they've been out of the hospital to ask more questions?
They can. Sometimes those calls come to care management, to the social workers or the care managers. Sometimes those calls go directly to the unit that they discharged from.
I see.
It really depends, but they have both ways to contact, and we do get a fair number of calls just to clarify, or they maybe weren't ready to consider an option while they were in the hospital, and they've gotten home and they've had some time to think about it, and now maybe they are interested, and so we get those calls.
Well, that has to be comforting to the patient and the family to know that they do have a resource.
Absolutely.
Yes, yes. I have a question to open up to both of you. Although your decisions about a patient's release are made in the patient's best interests, these decisions can also affect a hospital. Could you please explain that?
Well, I can start.
Okay, Dr.
The interests are aligned. Patients' interests, hospitals' interests, physician and providers' interests, I think, are perfectly aligned. We all want perfect, safe discharge disposition for the patient, and so we really focus on the patient's needs at the time of discharge. Our goal is to provide a discharge disposition that's going to allow the patient to thrive after they're hospitalized, and sort of an extension of that goal is to prevent readmissions from occurring, and so it all starts with focusing on the patient's needs.
Okay, and I do get the sense that this is a team approach. Many people bring in their ideas and form a consensus for this patient's discharge. Is that true?
It is true. It is a team approach. Physicians, social workers, physical therapy, pharmacy, dietary. I mean, in the nursing care, it is a team approach, and those teams meet daily to discuss patient needs and plans.
Every day, the hospitalist team meets in the morning, and care management is part of that discussion, part of that determination on each patient's needs, and so we really facilitate that team process.
Consistency and continuity of care is so important to patients. How do each of you achieve that in your own respective duties?
Well, I think that this happens across the hospital, but preparing that patient for who's going to be their caregivers. And so in a hospital setting, you have a lot of staffing, and you have staff that may work one day but not be there the next day. And so we used a standardized approach in terms of introducing and preparing that patient for what the day looks like. And the families are involved in that. But if you're not going to be the caregiver then for the next shift or the next day, then you prepare them and let them know. If you know the name of the staff person that's going to be taking over, you do that. But you prepare them that they're not going to see you the next day and why. And that provides some level of consistency and prepares them.
Okay. Do you have a quick word, Brian?
Yeah, from the hospitalist perspective, just collaborating with the professionals who do a great job of facilitating that discharge management, and that again is collaborating with the care management team.
Okay. Dr. Brian Bossard, Susan Mulligan, thank you both for being with us today. You're such an important part of Lincoln's healthcare, and we appreciate everything that you're doing. Thank you.
It's a pleasure. Thank you.
And remember, it's never too late to live and learn.
Hello, I'm Chris Beckenbaugh. Welcome back to Live and Learn. My guest today is Amy Goldman. Amy is with the Madonna Rehab Hospital. Hi, Amy.
Hi, how are you?
Good. How are you? Glad to have you here today.
Thanks for having me.
Of course. Well, Amy, you're a stroke program manager at Madonna. Can you tell us a little more about that?
Yes, for the past 8 years, I have been the stroke rehab program manager at Madonna. I am also a physical therapist by background. I've been at Madonna for 13 years. And essentially what that role involves is I help manage the programs all the way from inpatient through outpatient across the continuum of care. I do a lot with program development, making sure we meet the quality standards for our program. And I also do a lot with referral development and marketing of our program.
Okay, well, you've brought up a whole bunch of different terms there that I think we want to kind of rewind. So there are different levels of rehabilitation care that people might need.
Yes.
Okay, can you tell me about those?
First of all, obviously when a patient's in the acute care setting, they have a decision to make, and there are different levels of post-acute rehabilitation care for patients depending on their injury, the severity of their injury, and that sort of thing. Some of those include what's called the long-term acute care hospital, which is also deemed the term LTAC, and that is essentially for patients who are more medically complex. They might have a pretty complex cardiac condition. They may still be on a ventilator and needing to wean off the ventilator. Patients with multi-system or multi-organ failure. Patients who have had a very severe traumatic brain injury or spinal cord injury and require more comprehensive daily medical care that's more intensive than another setting might provide. The next level after that would be what we call acute rehabilitation, and that is that intense 3 hours a day of therapy required to maintain that level of care requirement for the patient, where patients would still be seen by a physician each day, daily nursing care, just like on LTAC. However, at this level of care, they need to be able to tolerate 3 hours of therapy a day and also be needing that comprehensive focus of therapies that's focused both on their medical and rehab needs.
Okay, so somebody may have gone to a hospital for a heart attack, an injury, spinal cord injury, some kind of traumatic brain injury, and so we're talking about levels of care coming out of the hospital setting.
Yes.
Okay, so we've gone through two of them.
The next step down from acute rehab, essentially as you're progressing through the continuum, which would be a little bit more lower intensity, is what we call the skilled nursing facility or the transitional care unit, which is that SNF level of care or skilled level of care where patients may only need about an hour to an hour and a half of therapy a day. It's less intense. You will not, at that level of care, have a daily physician need anymore. The physicians on those units typically see patients. It can be as long as every 30 days that they require a physician visit. However, at a lot of facilities, it's at least weekly or every 2 weeks. But the requirement is monthly versus daily. At that level of care, patients may receive PT/OT and speech just like in acute rehab and on LTAC. But again, it's not the 3 hours of therapy a day. It's a little bit less intense. And for those patients that typically go to a skilled nursing facility, they really are patients that may just have, let's say, an orthopedic condition or a less complex diagnosis. So typically not going to be a good fit for somebody with a spinal cord injury per se, or a young stroke survivor, or maybe someone who's had a brain injury, because the comprehensiveness of the services provided at that level of care is just not available.
So what we're talking about is rehabilitation after some kind of either hospitalization or injury. So what sorts of diagnoses might require then some rehabilitation after care? So
Great question. Any type of acquired brain injury, neurologic injury, such as a stroke, traumatic brain injury, spinal cord injury, patients who, we've seen a lot more patients who have had what's called Guillain-Barré syndrome, other syndromes that are neurologic in nature that lead the patient to having problems with motor control. They might have weakness, trouble swallowing, trouble balancing themselves and walking with their mobility. So whenever you have those kind of multi-systems that are involved, you want to consider rehab. Another condition possibly would be orthopedic. However, if let's say they're after a total hip replacement or a knee replacement, those patients may or may not need intense acute rehabilitation. They may be better served in what I described as that skilled level of care or a transitional care unit.
Okay. And some people might go home and have outpatient therapy.
Exactly. For patients who really are deemed very stable and don't have a lot of rehab needs, they may choose to go home. However, I like to point out to families, often even a couple weeks in rehab can be better for them in the long run than going straight home. Typically, patients that go straight home do not have a lot of the medical needs that they need to be in the hospital for anymore, but they still may need 2 to 3 times a week of therapy. And in that case, they may get what we call home health services, where therapies and nursing would come to their home, which is very convenient for them, and do the therapies right there in their home. But again, I like people to understand that would not be daily. That is typically 2 to 3 times a week. And then the visiting nurse may come once or twice a week to manage things like their diabetes, their medication. Maybe they just had a PEG tube removed and they need some wound care. Maybe they have an abrasion or a wound that needs to be monitored. And so the nurse would take care of those sorts of things in the home setting.
Okay, so we've talked about, that really high level of care where somebody's got some other disease processes along with what they're in rehab for, all the way down to somebody who maybe has had a knee replacement, spends maybe a day or 2 in the hospital, and then can go home and do their outpatient physical therapy.
Yep, that's the last one to comment on, would be more of the traditional outpatient-based therapies. And just for the general public to understand, there's a variety of different types of outpatient services. So again, making yourself aware of what services you need is very important, meaning some places specialize more in what we call neurologic outpatient therapy versus that sports medicine orthopedic type focus that, again, maybe that knee replacement patient may do better at. But if you have a condition like a stroke or brain injury or spinal cord injury that requires specialists that have knowledge in neurologic conditions, it's important that you shop around for that type of program that best meets your needs, which can be up to 2 to 3 times a week for traditional outpatient, and or what we call the rehab day program. There's only one facility in the region that offers a more intense outpatient day rehab program, and that is where patients may come up to daily visits, where they're at rehab for 4 to 5 hours a day in an outpatient setting, working on things like getting back to their home, community, back to work. All of those skills that are required to return to those life roles need to be addressed in an appropriate manner and at the appropriate timing of their recovery.
So quickly for our audience, you talked about PT, which is
Physical therapy.
and then OT.
That stands for occupational therapy.
Okay, and the difference between those two?
Physical therapy focuses more on your balance and mobility deficits after any type of injury, also focusing on strengthening, cardiovascular endurance, aerobic conditioning, and then occupational therapy, by the way it's titled, really focuses more on your daily living skills, returning to work. What are your occupational and life roles with what you want to get back to? So they're more focused on that work and home, occupation-based sorts of things.
And then speech therapy is helping people learn to speak, as well as
also
swallow and
swallowing,
eat.
which can be really
Okay.
critical after any type of, for instance, a neurologic event that might impair the patient's ability to swallow. They really work on what we call dysphagia, which is a swallowing disorder caused by a brain injury. And in addition to that, they do a lot with communication and speech and language disorders, where they address problems patients may have with not only getting the words out, which we call aphasia, expressive aphasia, but also receptive aphasia, which is their ability to understand verbal language by what somebody's saying to them.
So someone has spent some time in a hospital after a traumatic injury or some kind of illness, and they've got to make a decision on rehabilitation. What kind of conversation is had at the hospital at that point?
Typically, what I understand happens in the acute care setting is patients have a social worker assigned to their case and/or a discharge planner. So that individual meets with the patient and family as it gets closer to discharge time and gives them several options for what post-acute rehab services are available to them. And by the both federal and governmental, and as well as the accrediting body standards, they should be offering patients multiple choices for who that post-acute rehab provider will be.
So going through those questions that you talked about, how much medical care is needed, what's the intensity of rehab, does the condition require a healthcare provider of a certain type, and then how involved will the patient and the family be in the support and education going forward?
Those are all great questions to consider. We encourage families, when we meet with them, to consider all those things as they're looking for the right provider and
So
the right level of intensity
If there
following.
was a message that you wanted to leave with our viewers, what would be something you'd want them to remember?
I would just say it's very important to educate yourself. Unfortunately, no one expects to wake up and have stroke-like symptoms or be in a motor vehicle accident where you're required to make a rash decision. And you may not have all the tools to do that. So it's good now to be thinking about, if this would happen to me or my loved one, what would I want for them? And what are the different levels of care that are available to them in their community that can best meet their needs?
Well, we've made that information available as well in this edition of Living Well magazine. There's a whole article on rehabilitation, and we'd like to make that available to our viewers. Well, Amy, it's been a pleasure to have you here. Thank you for sharing with our viewers.
Thank you.
Remember, it's never too late to live and learn.
Hello, my name's Tom White, and my guests today are Joyce Kubicek and Sandy Lutz from Aging Partners. Welcome to Live and Learn. And our topic today is, okay, I've been in the hospital or I've been in rehab. Now what? What do I do before I leave? That's my first question, is what would I do before I leave the hospital or the rehab?
Well, I would suggest that you try to talk to the social worker or the discharge planner as early as you can after you get to the facility, to ask them. They have lots of experience. They know what other people have done when they've gone home. Sometimes if it's a rehab facility, they can even do a home safety check with you to see what in your particular situation would improve how things go for you. So that prevention is really important, and being proactive, think ahead. So even if you don't think this might happen to you, we're hoping today we plant the thought of, hey, maybe I should think about what I would do if I were in that situation.
So plan is a big part, and also talking with the social worker at the hospital or the rehab.
Yes.
Okay, and so Sandy, one of the things that we're talking about today is the Medicaid waiver program. Can you tell us what that is?
Yeah, I'd be happy to. The Medicaid waiver program is actually, it's Title 480, Home and Community-Based Services. It's funded with state and federal funds. The purpose of the program is to help people remain in their home or in an assisted living facility, and to either forego or eliminate going to a nursing home if that's a person's desire and if those objectives can be met safely.
Okay, and so what kind of help is available through the Medicaid waiver program?
The types of help are basically services coordination or case management and services. A services coordinator or a case manager, we're called services coordinators, meets with the individual and helps them determine what their needs are. The services coordinator also can monitor the provision of those services in the person's home. The types of services include in-home services and assisted living. If the person is living in their own home, they can get help with things like cooking, cleaning, bathing, dressing, laundry, transportation, lots of different great things like that to help them remain in their home. There's also different services that can be authorized. That includes things like home delivered meals. You might be familiar with things like Meals on Wheels. Adaptive equipment can be brought into the home, or adaptations to the home, and emergency response systems can be authorized.
So for instance, if someone might need in their shower, they might need a bar, that could be installed for them?
Yeah, you bet, right.
And so,
yeah.
What other, just some other examples of like?
Yeah, the program, we can authorize agencies to come in and provide the services to the individual, or individuals, you or I, if we have the skills, ability, and desire, can be authorized to go in and provide those types of assistance to the person. One of the nice things about this program is also family members may also be authorized to provide services and receive reimbursement for doing that if the family member is not responsible for the person, that is a spouse, or it doesn't work for our program, but for a person who is a parent of an individual. Generally, that's the younger population that we don't serve. But all others can possibly be authorized as providers and reimbursed for their time they spend helping the person.
So perhaps a sibling or a child can, if they're working a full-time job or need to cut back on their hours, they could be reimbursed.
That's exactly right. That's perfect. That's right. We have daughters, sons, adult grandchildren, neighbors and friends may also.
That's great. All right. So now, who all can participate in this program?
The program, through Aging Partners, the state of Nebraska contracts with all the area agencies on aging across the state of Nebraska to implement this program. So for people that are 65 years old and older, that are on Medicaid, and also have needs such that they could be in a nursing home. That is, the person needs help with doing things on a daily basis, like dressing or feeding themselves or walking or transferring. Those types of people might be eligible for our program. The person then needs to help us in determining what their care plan is and what their needs are, and agree to cooperate with the implementation of that care plan.
All right. And so how could I apply for the Medicaid waiver program?
It's very simple. Anyone can apply. If you were wanting to be on the Medicaid waiver program, you could call into Aging Partners. the number here, the 402-441-7070 number. We have an 800 number. I'm sorry, I don't remember it. It's on our website, though. Just call in, and just if you mention the words Medicaid waiver, they're going to channel you, the people answering the phone will channel you to the right person to help you with the process. But if you're not able to call in, or maybe you don't recognize that you need the help, a family member, a friend, a doctor, a caregiver, maybe a pastor, they could call in for you and make the referral. Typically it's all over the phone that we get the referrals. Sometimes it's walk-ins. On occasion, people will actually walk into our office and request to apply for the Medicaid waiver program. After basic information is gathered, then the person is assigned to a services coordinator or care manager. That services coordinator meets with that person in their home, assesses and completes an assessment. That needs to be done within 14 business days of the initial referral. And during that whole process, the services coordinator will talk with the individual and their family members and determine what the person needs, what they want, who they want coming into their home, and the frequency of that. We'll put together a care plan. Of course, before that, determine eligibility. So that's basically the process. But back to your original question, call in.
It's
easy.
Yeah. It sounds like it's not too much involved in it. So
yeah.
All right. Now, Joyce, say I'm not eligible for the Medicaid waiver program, but I still need help in finding home services. And what can I do to find help at home?
Well, there are a number of programs for people that are not on Medicaid but still need in-home help. And we have an information and referral. We call it First Service. It's the same phone number that Sandy had because we all work together, so we can help you find the right doorway to go through for you. And when you call in, or you can go to our website, it will list the agencies in our community and in our 8 surrounding counties that provide in-home help, very similar to what Sandy is describing. Mm-hmm. The difference might be that if you are low income and on Medicaid, you might receive that help at no cost. Mm-hmm. If you are not in that situation, you might be paying privately, or there might be some other programs that cover some of it also, help defray the cost. So we can help tell you about those things. We kind of call it a benefits checkup. You come in and we go over your situation, or on the phone, and we kind of guide you toward things you might want to look into.
And so what can I do to ensure that I am safe in my house? What types of things?
Well, as Sandy mentioned, some people have a personal emergency response system. There's a number of them in our community. Aging Partners has one through the Home Handyman Service, but there are a number of them. It's something you see people with a little pendant or wrist band that if you want to live alone but you want to get help if you really need it in an emergency, that's an option. I think it's very important, and I think sometimes as people get disabled or getting older, they may become more isolated. Maybe that neighbor that lived next door has moved away. Maybe friends, you've lost some friends, or families moved away. So it's important to think about your support system. You know, how could I make it bigger? Maybe I need to admit to my pastor that I wish, some of my church friends would visit more frequently, or maybe I need to go down to the senior center and meet some new people, or we just need to be open to broadening our support system sometimes, because isolation can be really affect our safety if people don't know that we need help when we do.
Now, we were talking about caregivers before, and how can I help the caregivers be successful?
Well, if I was older and frail and there was one person that was my main caregiver, I would say I would hope that I would think, oh, this person is great and I want a lot of help from them, but maybe I need to pump up the number of people who help me. Because a lot of times caregivers are very giving people, they want to help, but they get burned out and they need respite. And so it's okay to talk about that. It doesn't mean that that caregiver doesn't care about you just because they want a break. And it's really nice if I, the person getting the care, can remember to try to look for ways to have a few more caregivers. And sometimes people just need to be asked. They think, oh, well, your daughter does such a beautiful job, I don't want to get in the way of that. But it's okay for that person to say, on Tuesdays, I wish you would come and give my daughter a break, or something like that. So I think respite is important, is my message. So.
Well, thank you so much. Thank you both so much for coming in and talking to us about this today. And my guests have been Joyce Kubicek and Sandy Lutz from Aging Partners. I'm Tom White, and remember, it's never too late to live and learn.
I'm Harlan Johnson, and you know, I was surprised to learn that the senior centers have been around Lincoln for 40 years. They started in 1974, and Bob Esquivel is my guest today. He's the senior coordinator for the centers. And so, Bob, you've got a lot of things planned for the coming month of September.
You bet. September is going to be our big anniversary for our 40th. We were celebrating an open door since 1974. As you asked earlier, the fine art of experience is one of those things. We're going to have a big opening for that on the first Friday, which is Friday, September the 5th, from 5 to 7 p.m. This is going to be an art show that's going to feature the work of artists over the age of 65 who will be doing portraits of other artists over the age of 65. And it's going to be a wonderful opening that night with some entertainment and some refreshments and, of course, some wonderful art.
And also back in the 70s, you know, Big Red was rolling big in those days. Tailgating was big. Now tell us about the tailgate memories.
Okay. 1970s Tailgate Memories. That's going to be a fundraiser for our senior centers. We're going to be doing it out at the Playmore Ballroom, which is at 6600 West O. We're going to be featuring two wonderful performers who've been in our area for quite some time, Johnny Ray Gomez and Jimmy Mack, who've been kind enough to get on board with us to do this celebration. We're going to have a lot of raffle drawings that evening, again, some great music, hors d'oeuvres, and our sponsors I want to make sure that I mention because you need a lot of help when you're doing things like this. Our gold sponsors, the Legacy Retirement Communities, silver sponsor, Billy's Restaurant, and our bronze sponsors, Horizon Hospice Community Foundation. God, it was hard to trip out of my tongue there. And our other bronze sponsor, Home Instead Senior Care. It's going to be a photo booth, a whole lot of fun that night.
Now, Brain Matters, that's important. It's a health fair. What's all that about?
I can't remember. No, that's not true. No, as we age, we all realize we start to worry more about our mental acuity and about our memory and our brain function. This is our second annual event of this type where we're going to have a couple of speakers talking about some important aspects of that, and a vendor fair that's going to feature booths from businesses and organizations locally that have a lot to do with this very issue. It's going to be out at the Marcus Edgewood Cinema, 56th and Highway 2. Our speakers are going to be Dr. Allie, who you've probably heard of. I know our viewing audience has. She's going to be Dr. Allie Daring, there we go, and also Don McKenna. Dr. Allie is going to be talking about the potential memory issues with drug interactions, and Don McKenna is going to be talking about the value and the positive effects of meditation on brain acuity. So we're looking forward to that, and if you want to sign up for that, we do need you, although it's free, we do need you to call because there's limited seating at the theater, and you can call 441-6156 to make your reservation for that.
Now, the next one includes a couple of very familiar Lincolnites, John Roth, Mary Jane Nielsen, talking about history.
That's right. Those are the kind of folks you go to when you want to know more about what went on in the 1970s. And of course, because that's our focus on this Open Doors since '74, we're going to be doing a luncheon that will feature those two with some wonderful nostalgic photographs of Lincoln in the 1970s, in the disco decade. In fact, that's what we call it, Lincoln in the disco decade. And the main dish that day is going to be something that's as old as I am. Back in 1949, the Runza restaurants started their first restaurants, and so they're going to be catering our main course. We'll have some additional foods along with that, but it's a great program. They, of course, have done lots of books like Looking Back, Lincoln, a street called O, When I Was a Kid in Lincoln, those kinds of books. They're going to be there to do a look and a discussion and some memories about a nostalgic look back at the 1970s here in Lincoln.
Now that's September 25th, and where is that?
And that's going to be at the Firefighters Reception Hall at 241 Victory Lane.
Okay. You know, September is actually Senior Centers Month, and of course it takes a lot of planning, and you've done a lot of planning for some interesting things. Thanks, Bob, for coming and being on the Live and Learn show.
I do want to mention
that
if you want a more detailed look at all the things that we're going to be doing during the month of September to celebrate our 40th anniversary, get your Living Well magazine out, look at page 18, and all the items I've discussed here are going to be there, but in a much more detailed way.
Thanks, Bob, for coming and being on Live and Learn. And remember, it's never too late to live and learn.